Acute hemorrhage in acute promyelocytic leukemia is an oncologic emergency. Hemostatic support, transfusions, plus definitive treatment, AERA to halt procoagulant release. I are the key. Hourly assessment is critical. A stable APL patient can decompensate in minutes. ATRA stands for all-trans retinoic acid. ATRA is a derivative of vitamin A. It is not traditional chemotherapy. In acute promyelocytic leukemia, the cancer cells get stuck at an immature stage, promyelocytes. These abnormal cells release substances that trigger the severe coagulopathy, DC, seen in the labs. Mechanism: AERA forces those malignant promyelocytes to mature, differentiate, into normal, healthy neutrophils. The procoagulant release effect: by forcing the cells to mature, ATRA stops them from releasing the tissue factor and cancer procoagulant that is causing the low fibrinogen and high D-dimer. It effectively turns off the DIC machine. Definitive treatment: AERA to halt procoagulant release. This is because the bleeding risk, driven by the low fibrinogen and platelets, will continue to worsen as long as those malignant cells are alive and circulating. Transfusions, hemostatic support, by raising counts temporarily. ATRA treats the root cause, so the body stops consuming clotting factors. Because AERA causes the cells to mature rapidly, it can cause a capillary leak syndrome, differentiation syndrome. This is why hourly assessment is critical. Patients can develop fever, fluid in the lungs, and low blood pressure very quickly once ATRA is started. Patient: Ms. Elena Vasquez, 28-year-old female, newly diagnosed with APL. Day 3 of induction therapy, ATRA plus arsenic trioxide. Clinical presentation: vitals: BP 100/58, HR 128, RR 24, temp 37.8 degrees Celsius, SpO2 96% Ra. Physical exam: petechiae on oral mucosa/chest, ecchymosis on arms. Gingival oozing, epistaxis, slow trickle, right nostril. Neurologic: alert but anxious, denies headache. Symptoms: my gums won't stop bleeding, fatigue, dizziness. Labs stat: platelets 12,000/mm superscript 3. Fibrinogen 80 milligrams per deciliter. PT 28 seconds, APTT 55 seconds. D-dimer 8,500 nanograms per milliliter. Hemoglobin 7.2 g/dl. Immediate nursing action for gingival oozing: A. Administer tranexamic acid mouthwash. B. Apply ice-packed gauze with pressure. C. Position supine to reduce BPD. Give IV morphine for anxiety. Answer B. Local pressure controls capillary bleeding. Ice vasoconstricts. Priority lab indicating DIC. A. Platelets 12,000/mm superscript 3b. Fibrinogen 80 milligrams per deciliter plus elevated D-dimer. C. Hemoglobin 7.2 g/dld. PT 28 seconds. Answer B. Low fibrinogen plus high D-dimer confirm DIC. A PL complication. DIC is characterized by consumption of clotting factors and simultaneous clotting and bleeding. Fibrinogen 100 to 150 mg/dl due to depletion of clotting factors. D-dimer increase reflects fibrin degradation from widespread clot breakdown. Therefore, low fibrinogen plus elevated D-dimer is the most diagnostic pattern for DIC. Patient reports sudden severe headache. Next action: A. Administer acetaminophen. B. Assess neurologic status plus stat head CTC. Elevate head of bed. D. Notify provider in 1 hour. Answer B. Sudden HA suggests intracranial bleed. CT confirms. BP drops to 88/50. Most urgent intervention: A. Transfuse platelets. B. Bolus 500 milliliters 0.9% in ACLC. Administer IV heparin D. Obtain ECG. Answer B. Fluid resuscitation restores perfusion before transfusions. Transfusion ordered. FFP. Nurse's priority. A. Verify blood type compatibility. B. Premedicate with diphenhydramine. C. Use 22-gauge IV catheter. D. Infuse over 60 minutes. Answer A. FFP requires ABO/RH compatibility to prevent reaction. Contraindicated medication for this patient. A. IV vitamin KB, ibuprofen for pain C, ondansetron for nausea D, prochlorperazine. Answer B. Since this patient already has a critically low platelet count and is at high risk of spontaneous intracranial or internal hemorrhage, using a drug that further impairs the function of the few platelets they have could trigger fatal bleeding. PKI on chest worsening. Nurse interprets this as A. Allergic reaction B. Progressive thrombocytopenia C. Infection D. Fluid overload. Answer B. Petechiae indicate platelet consumption/thrombocytopenia. Patient develops bright red urine. Suspected cause. A. Dehydration B. Hemorrhagic cystitis C. UTI D. Nephrotoxicity. Answer B. Hematuria in APL suggests hemorrhagic cystitis or renal bleed. Gross hematuria in acute promyelocytic leukemia, APL, or undergoing chemotherapy raises concern for hemorrhagic cystitis, often caused by chemotherapy agents, e.g., cyclophosphamide, ifosfamide. Radiation therapy to the pelvis. Severe thrombocytopenia or DC from APL, which leads to bleeding in mucosal linings like the bladder. In immunocompromised or oncology patients, hemorrhagic cystitis must be treated promptly. Ensure adequate hydration. Stop or adjust offending agents, e.g., cyclophosphamide. Consider mesna prophylaxis if not already given. Critical teaching for preventing injury. A. Use electric razor, not blades. B. Ambulate 3 times daily. C. Increase fiber intake. D. Take hot showers. Answer A. Avoid skin trauma, prevents spontaneous bleeding.
D-dimer elevated. Pathophysiology explanation. A. Indicates liver failure. B. Signals uncontrolled clot breakdown. C. Suggests vitamin K deficiency. D. Shows platelet destruction. Answer B. D-dimer elevation equals fibrinolysis, DIC hallmark. Stat order, platelet transfusion. Expected outcome. A. Hemoglobin increase to 8.0 g/dl. B. Platelet count upward arrow by 8,000-10,000/mm superscript 3. C. Fibrinogen normalizes. D. PT decreases to 12 SEC. Answer B. 1 unit platelets 8-10K/mm superscript 3 increase in adults.
Nurse notes tarry stool. Priority action. A. Test stool for occult blood. B. Increase fluid intake. C. Administer laxative. D. Obtain abdominal X-ray. Answer A. Melena indicates GI bleed. Occult test confirms. Patient vomits coffee ground emesis. Indicates A. New onset infection. B. Upper GI bleed. C. Chemotherapy toxicity. D. Bowel obstruction. Answer B. Coffee ground emesis equals digested blood, upper GI source. Discharge teaching priority. A. Report nosebleeds lasting greater than 10 minutes. B. Restrict fluid intake. C. Avoid all physical activity. D. Double vitamin C dose. Answer A. Prolonged bleeding signals thrombocytopenia/DIC recurrence.
Life-threatening complication requiring ICU transfer. A. Platelets 15,000/mm superscript 3. B. GCS 10 plus unilateral pupil dilation. C. Temp 38.5 degrees Celsius. D. RR 20/min. Answer B. Altered LOC plus pupil change equals herniation from intracranial bleed. APL bleeding emergency protocol hemorrhage, NCLEX mnemonic. Hemodynamics first, fluid resuscitation. Elevate hop 30 degrees, downward arrow ICP if cerebral bleed. Mouth care, soft toothbrush, ice packs. Omit NSAIDs/anticoagulants, strict contraindication. RBC/FFP/platelets per lab thresholds. Reassure plus anxiolytics, downward arrow BP spikes. Hourly neurochecks, for intracranial bleed. Avoid invasive procedures, rectal temps, IM injections. GI protection, PPI for stress ulcers. Education on bleeding signs, discharge priority. APL equals highest bleeding mortality of all leukemias. Platelet 10K/mm superscript 3 plus fibrinogen 100 mg/dl equals active DIC. Transfusion triggers. Platelets, 10K/mm superscript 3, or 20K for fever/bleeding. Cryoprecipitate, fibrinogen 100 mg/dl. FFP, PT/APTT 1.5x normal. Never administer heparin, NSAIDs, aspirin.